ventilate scenario in emergency room. Let us see for the scenario. A 50-year-old severely obese female patient presented to ED with complaint of cough, fever, and difficulty in breathing since 2 days. On arrival, her SpO2 was low, which was increased to 88 with NRBM. Her pulse rate was 98 per minute, low volume. BP was also low, but the respiratory rate was 30 to 35 per minute. Her ECG was showing STT changes. So, management was started in emergency room. But in spite of all measures in emergency room, she continued deteriorated and required intubation. So, how we will manage this? So, the ER staff is given injection propofol 100 milligram IV, and the intubating person tried to ventilate her with back and mask ventilation. He could not ventilate it. So what we should do? Intubate. Okay, then he tried to do laryngoscopy, but he was not able to see anything on laryngoscopy. So what's the scenario? He also tried 2-3 times, but he done some other efforts also, but he could not intubate. So what's the scenario? CICV. So how to manage? What is our priority? Intubation or ventilation? Okay, let us see. So my objectives are, what is CICV? It's important in emergency room. How to manage scenario? Maximize success rate of airway management, improve patient safety, minimize and avoid adverse events. So what is CICV? It's a can't intubate, can't ventilate situation in emergency room. So the oxygen delivery to the tissue is affected. Why it occurs? It occurs due to airway obstruction that persists despite all reasonable efforts of traditional intubation and STA devices. It's not common in emergency room, but when it occurs, it is very crucial and so require immediate management to prevent inadequate ventilation, hypoxia, aspiration, airway trauma, cardiac instability, arrhythmias, brain damage, cardiorespiratory arrest, and death. So, what are the indicators that means absent or inadequate chest movement, absent or inadequate breath sounds, auscultatory signs of severe obstruction, cyanosis, decreasing or inadequate oxygen saturation, and hemodynamic changes like hypertension, tachycardia, bradycardia, arrhythmias related to hypoxia and hypercarbia, you may be seen. So how will you manage? So these are the steps by which we can manage CICV scenario. So let us see one by one. So how to manage? So as soon as you suspect or you think that this may be the CICV scenario, immediately call for help. For whom? First, you call the expert person. Even though it is not CICV declared, you call him, because when the CICV situation occurs, if he will be present, he can immediately help and intubate this patient. So whom you will call? We will call our senior experienced person, anesthesiologist, maybe ENT, surgical people who is performing tracheostomy routinely. We will do ultrasonography and emergency room staff. I instruct my emergency room staff to prepare for difficult airway, blind nasal intubation, video laryngoscopy, fiber-optic intubation, and FONA. So how to optimize oxygenation in this scenario? By providing emergency flush through the ventilator or high flow oxygen through BVM or face mask. Also, we can do the manual maneuvers like reposition the head and neck, provided pillow under the shoulder, and if the other person is available, then one person will hold the mask properly with 2 hands and the second person will ventilate with back and mask ventilation. Also, one can apply BURP to improve the laryngeal view, and if there is blood, suction or secretion or vomitous material, then we have to do suctioning to make the oral cavity clear and improve our view. Here I have some confusion whether we should administer sedative or not, and whether it should be awake or blind. So if the anatomy is disturbed and you are not able to do any other things, then don't give paralysis. But you think that you are able to see some things, And by improving the maneuvers or by relaxing the patient may have ventilation and we may deliver the oxygen. Then we may provide sedative, but don't provide in huge amount or high overdose. So the patient may undergo cardiac arrest and nothing will remain in your hand. Again, awake or blind, that depends on the condition of the patient. If it is during CPR, there is no question of awake. At that time, we have to do blind intubation because all other measures have failed. Again, if it is for stroke or for prophylactic intubation and you have given induction agent, then you make the patient awake. So awake patient will have some oxygen exchange and brain damage can be prevented. In emergency room, most of the intubations are done on the hospital's bed. We all know what is the position when patient is in hospital bed. When we are resuscitating the patient, maybe CPR is ongoing. At that time, the scenario is worst. There is headboard on the head and side of the patient. Again, our mattresses are soft. So resuscitation during CPR, the head is moving up and down. And even though we are expert, we may not be able to see anything. So at that time, stop CPR, insert the laryngoscope into the mouth, try to see the larynx, and then ask them to stop CPR for a while. As soon as they stop compression, make the V possible and intubate. And immediately once you insert the tube, allow them to start chest compression. And remember that any maneuver you will do, you will not discontinue the chest compression more than 10 seconds. Okay, so how you will take your position? Then you remove the head and side of the headboard, then place a folded linen under the head, so you can be able to obtain the sleeping position, and then you try for intubation. How to manage with the equipment? So if your conventional blade is not suffice, then you may change to straight blade or Trupti blade. Trupti blade is having whether you are in the proper position or not, and if there is flooded of the oral cavity with fluid secretion or mouth, then you must do suction and you can improve your view. Then how the SPA devices help you? The fast track intubating LMA, they help you in intubation, but IGL, laryngeal tube, OPRA, PLA, and AirQ, they relieve the upper airway obstruction and they help you in oxygenating this patient and you can maintain ventilation through them. Many persons prefer endoscope, but we all know there is limited role of video laryngoscopy and fiber optic intubation in emergency room, and specifically in CIVE when it is unanticipated. But definitely, if the intubation is anticipated, then you keep all these things ready, and as soon as you declare that it is CICV, then immediately you use video laryngoscope and you can intubate this patient. This is helpful in restricted neck movement patient, morbid obese patients, airway edema, pre-existing scar, history of radiation, and mass. But definitely, you have to be very careful when there's blood in the airway cavity and limited mouth opening, because you cannot manipulate inside with your laryngoscope. And for that, you have to look at patient until the EDT appears on monitor. Before that, you forget monitor and you see inside the oral cavity. Now, invasive airway management. So, what are they? The FONA and jet anti-ventilation. So, what is FONA? Front of neck assist. How? By cricothyroidotomy. What is it? It is a placement of needle or tube through cricothyroid membrane for ventilation, and it is a part of American Society of Anesthesiologists and Difficult Airway Society as a difficult airway management algorithm. Why CT membrane is chosen? Because it is more superficial, easily palpable, and less mobile, so it can be held steadily. Also, it is avascular, so there is less bleeding. And again, it is easier and fast to perform cricothyroidotomy than tracheostomy. Which are the various types? Needle, percutaneous by Salinger techniques. Here it is dilated, so no scar after removing the tube. And third one is the surgical incision.
So what are the indications of cricothyroidotomy? So acute obstruction of the airway, penetrating the neck trauma, expanding hematoma, blood flooding in the oral cavity, blood vessel trauma, subcutaneous emphysema. So how needle cricothyroidotomy is done? Here the needle is injected in cricothyroid membrane and it is connected to high flow oxygen source. Here the diameter is less than 4 mm. Advantage is that it is less invasive and less bleeding. But the disadvantage is that it's purely temporary measure. It is not a definitive airway. It allows oxygenation, but CO2 may retain. And the foremost requirement is that it requires patent airway for exhalation. Coming to percutaneous cricothyroidotomy. So here the special prepared device is available, but it is applicable only when some time is permitted, because once you introduce the needle, you will introduce the guide wire and dilate that part, and then you will introduce that. So it will take some time. So some oxygenation or some ventilation is possible, then and then it is used. But in pure CICV scenario, it has no role. Here, 14 to 16 gauge cannula is inserted. Its inner diameter is more than 4 mm. So it allows exhalation also. It avoids the need of jet ventilation and is less invasive than the surgical cricothyroidotomy. Now coming to surgical cricothyroidotomy. The ideal size of the tube used is 6 mm tracheostomy or 5 to 6 mm endotracheal tube. Here I have pasted the table exactly same as internally, so the student can remember where it is given and how to do it. Because of time constraint, I will skip this, but the students can read it from the internally. Now coming to the incision. Surgical thyroidotomy is an incisional cricothyroidotomy. So how to put the incision? So remember, there are two types, horizontal and vertical. So when you will put a horizontal and when you will put vertical incision. So there are some guidelines. See the picture. In picture, there is upper airway is disturbed. Problem is with upper airway, but the neck anatomy is normal. So if the neck anatomy is normal and it allows you for easy palpation of the cricothyroid membrane, then you go for the horizontal incision. Horizontal incision has better advantage of cosmetic purpose. Not vertical. So when you will put vertical, see the picture. There is short neck, thyroid swelling, or there is hematoma or something like that. You cannot identify the neck structure anatomy. Then you put a vertical midline incision, and then you separate the skin, subcu and fascia, and then you try to palpate the cricothyroid membrane through that. And once you are able to palpate the cricothyroid membrane, then put incision on the cricothyroid membrane. Here the steps are given. Again, I have pasted the same table given in internally. The figures are showing that first figure is palpating the cricothyroid membrane. Second, put the incision and dilate separate the skin and subtube. In third, you are palpating the cricothyroid membrane, identifying the cricothyroid membrane. On fourth, you are putting incision on the cricothyroid membrane, then dilating it. And in fifth figure, it shows that you are inserting the tube. So what is the difference between surgical and cannula cricothyroidotomy? Though the NAP for Edric in UK found that surgical cricothyroidotomy has more success rate compared to cannula cricothyroidotomy because it has wide exposure and wide area to see our incision. But many traditional surgical, and also they have shown that traditional surgical cricothyroidotomy procedure is faster than the cannula cricothyroidotomy experience. Now, what are the jet ventilation? What is jet ventilation? Here, the 16 gauge needle catheter is introduced, and the ventilation is started with the specific device. Here, you are showing there is some pressure gauge, cannula, and the needle. So this all kit is used for the jet ventilation. Here, these are the equipments for ventilator. So here again there is a table. You can read the technique from the poster. Again, in figure, you can see the needle is introduced and air is aspirated to see that it is free flow of the air. Jet ventilation is a procedure. So what are these complications? Damage to the trachea.
Please stay tuned. Another video is coming up.
Yes, sir. Yes, sir.
Most time. Again, in figure, you can see the needle is introduced and air is aspirated to see that it is free flow of the air. Jet ventilation is a procedure. So what are these complications? Damage to the trachea or perforation of the lateral posterior wall, bleeding at the puncture site, infection, massive subcutaneous emphysema, and barotrauma if there is excessive ventilatory force is applied. Also, it requires constant surveillance of the chest rise and appropriate exhalation. The advantage is that it rarely causes long-term airway complications and allows more control approach for the next round, and also it prevents the lung collapse. Now, we have seen the non-invasive technique and invasive technique, but if all others are failed, then we might have to use combination of technique. Means for doing needle cricothyroidotomy or surgical cricothyroidotomy, we take the guidance by the video laryngoscope or fiber-optic laryngoscope. We put it in the oral cavity, and under its guidance, we do the cricothyroidotomy. And for that, we use the different equipment, different technique, and also ultrasonography of the airway is also helpful in putting the tube in. Now, ECMO, the latest research says that ECMO is helpful, but how and when? If it is anticipated at that time, we have kept the ECMO ready, and then only it is useful. Otherwise, in busy emergency room, if I get CICV, ECMO has no role because it requires special setup, and some time is always taken to put the cannula, start the machine, and setting the machine. Also, we have to sit the patient to the ECMO suits. So, if there is some oxygenation is possible in any patient, then and then by continuing some oxygen, we shift the patient to the ECMO room and we start the procedure. Also, ECMO has its own advantages and disadvantages. So, in CICV, you have managed the scenario. What is the follow-up? Once your emergency is over, condition is treated, and patient is extubated, or patient is weaned off from the cricothyroidotomy or surgical incision, something like that, then care is required. So, during procedure also, once the patient is settled and once you have done extubation, then also the care is required in form of nebulization or antibiotic and something like that. Also, once the condition is over, if patient is conscious, then with patient or to the relative counsel has to be done. They have to be kept in their mind that their patient or the patient himself had some problem with the airway while managing some scenario. So, he has to be given a documentation or in discharge card on block letter it is written a difficult airway management or CICV. So whenever he goes to any hospital, he produces that card and the treating physician knows that, oh, if patient will be critical, there will be some problem with the airway. So if he has that facility, then only he will admit that patient or he will shift the patient to other better care hospitals. Also, if the patient has difficult airway management, then it has to be documented in his medical records, and that record, part of the record or the copy of that part only should be given to the patient. Also, if there is difficult airway notification service in that hospital or in that area or in that region, then it should be registered with that services. There are some special persons who have problems of airway and they may deteriorate fast compared to other patients. The first is pediatric patients. What are the problems? They have shorter neck, more relative soft tissue, more compressible proximal airway structures, and less decreased thyroid and pituitary cartilage. So they deteriorate very fast and their safe happening time is also less. So we have to be very careful while managing such patients. The American Heart Association and others recommend that percutaneous transtracheal jet ventilation is used first in pediatric patients, and surgical cricothyrotomy is kept as a second choice. Pregnant patients, their anatomical and physiological changes contribute to more rapid oxygen desaturation. They have high risk of aspiration. So the best approach is to avoid intubation whenever possible. And so you treat them from the beginning in such a way that they may not require intubation. And even though they require intubation, you have to be very careful. Also, morbidly obese patients have challenges of airway management, mass ventilation, laryngoscopy, and emergency cricothyrotomy. Also, they have shorter safe apneic time, which causes rapid desaturation. And so, if CICV occurs, they may lose earlier compared to other patients. Some patients with head and neck cancer, so in that patients, awake intubation is preferred because it is the safest choice. And second is the fiber-optic scope, because fiber-optic scope has multi-axis movement and it provides you the whole area of where the tip is, and it allows navigation. So if anatomy is disturbed by surgical resection or radiation or other pathology, then you can notice that also. Coming to trauma patients, our many patients of trauma, they are coming with the head and cervical spine injury. If they require intubation, then the indications may be airway protection, mechanical ventilation, and emergency surgery. Or if we require to transport this patient to some other center like CT scan, MRI, or higher center, then we have to intubate such patients. So the problem is rigid cervical collar. It do not allow us to manipulate the head and neck. Second, their cormac and lens view of larynx will also be disturbed and we cannot easily identify. Also, they are at high risk of aspiration, and concurrent close head injury worsen the condition very fast. So we have to avoid neck movement during intubation attempts, and also we have to avoid hypotension, hypoxia, and hypercarbia to prevent secondary brain injury. So what precautions we should take? So if mass ventilation and laryngoscopy is difficult, then we should remove anterior panel of the rigid cervical collar. We should apply manual inline stabilization and the cricut pressure with minimal neck movement. But we have to be very cautious as some jaw thrust, mass ventilation, intubation, or SDA insertion causes some movement of the neck, and it will convert undisplaced fracture into displaced or stable fracture into unstable fracture. We all have worked in last 2 3 years with COVID-19. So what are the risks and what precautions we have to take? So we have to take highest level of available precautions with isolation and precaution. Once we get CICV, then most experienced persons will be called. It is not like that first junior will take, then higher grades, higher grade junior will intubate, and then the senior will come and try to intubate. It is not like that. Once you will declare or suspect CICV scenario, always ask for the most experienced person. Also, one should minimize the use of equipment, and the person should be outside the room with all equipment. Whichever is required, that equipment only will come inside, so everything will not be spoiled. Then we have to use viral filters in the circuit as well as near the Megan mask also. Also, early use of video laryngoscopy may allow us to maintain distance from the patient's oropharynx to us, and we may prevent the infection. Also, inline closed suctioning system is helpful in such patients. So, to summarize, whenever can't intubate, can't ventilation scenario is created, don't be panicked, but call earliest for help. Our goal is to ventilate and provide oxygenation and not to intubate. And remember, no technique is ideal and give guarantee of 100% success rate with any single technique. But based on scenario, we have to select appropriate equipment and technique and person depending upon the availability, training, expertise, and experience of the performer. We have to decide whether I will use non-invasive or invasive approach. Also, I have to weigh the risk-benefit ratio for each and every case. We have to choose another technique immediately if one fails, and do not waste time to decide whether I will use this or this. So our decision power should be strong. If required, we can use combination of techniques, and we have to avoid potential injury and complications. So it indicates that experts are available in emergency room, but they are not always with the patients, and they are not present in ER 24/7. And at that time, if CICV occurs, the danger effects will be in the minutes. So all staff working in emergency room must be aware and trained for the worst scenario of CICV. How? By presenting real life scenario, real screen video, workshops, hands-on practice on mannequin and cadaver, and simulation models. Remember, any trained person can perform airway management, but perform only those for which you are trained. All EPs must be trained on mannequins for at least 5 attempts or until their cricothyroidotomy time is less than 40 seconds. Also, we have to repeatedly train ourselves as the time passes, our performance alters. So repeated training is also required. So I request SEMI to organize such training frequently in regional area as a workshop or simulation, so we all can remain updated with CICV scenario. Thank you.